Today we're tackling the question, do bone spurs really cause pain?
That's right. We're going to bring in an expert to actually explain this and settle this myth once and for all. I'm Brad.
I'm Mike, and behind the scenes we have Bob, and together we're the most famous physical therapy team on the internet.
You said that pretty fast.
I did.
In our opinion, of course.
And if you're new to our channel and like this video, please subscribe. We do appreciate it. Brad,
Subscribe.
Brad, take it away.
All right. Now, bone spurs can occur in many parts of the body, and they do. But what we're going to do is focus on the heel and show how the symptoms of heel bone spurs can really throw off a diagnosis, but it can happen with any bone spur, including in the back, the knee, the shoulder, and it all relates as one.
So to clear this up, we're going to bring in an expert since we're talking about heel spurs specifically. We have podiatrist Dr. Ray McClanahan, who is an expert in this area and sees this a lot. So we're actually going to go to a clip from him, an interview we did with him a few years ago, and he explains it a lot better than we can.
That's right. And then actually in a bonus at the end, if you happen to have heel pain, this is going to be really directed towards you near the end of the video on how to correct it on yourself.
So we're going to start talking about heel pain. So what are some common causes that create heel pain?
Yeah, there's probably 2 or 3 common ones, but we have to be careful with heel pain because there's outliers as well. And we could talk about some of those outliers. For instance, if somebody comes in and both of their heels hurt at the same time, we definitely talk about footwear. We set up the rehab. We talk about toe separators and some of the other things that we do. But we also keep our thinking cap on in terms of autoimmunity, connective tissue disorders, infectious disease like Lyme disease and so forth, medication side effects. I've had people take antibiotics and have bilateral plantar fascial irritation. But overwhelmingly, most people that we see are dealing with something called plantar fasciosis. For the audience, this used to be called plantar fasciitis, which suggested that the ligament on the bottom of our foot, known as the plantar fascia, was getting inflamed. Actually, before I go into that, Mike, there are also probably 2 other things that we see fairly regularly, which are a bursitis under the heel, which usually doesn't hurt first thing out of bed in the morning like fasciosis does. Usually bursitis hurts also centrally under the heel instead of on the inside back part. There's also a couple nerves that go down the side of the heel that can get irritated by a hiking boot, a running shoe, a stiff orthotic, a seam inside of the shoe. But I'd say overwhelmingly what I've seen in 27 years is probably 8 or 9 out of 10 of those people have first thing out of bed pain in the morning that gets a little bit better as they move around, sit down again at lunch, hurts again until they move around a little bit. One of my medical school professors in Philadelphia, Dr. Harvey Lamont, is not only a podiatrist, he's a dermatopathologist. So he looks at tissue specimens under the microscope to find out like what kind of disease is this? What kind of inflammation is this? And he's like a lot of podiatrists and physical therapists and orthopedists that are seeing a lot of heel pain. And some statistics say it might be 40% of what we see. He did a histopathological examination of 50 of his patients, because if you fail what podiatry calls conservative therapy, which is ice and orthotics and injections and anti-inflammatories and physical therapy and maybe immobilization, you're going to get offered some kind of an operation to release your plantar fascia. And I did a lot of that early on in my career, and I'm glad I don't do that anymore. And I wish people wouldn't have that because some of those folks never really recover. But the point is, Dr. Lamont did that operation on 50 of his patients. And during the operation, he took a piece of their plantar fascial ligament and he looked at it under his microscope. And this study is also on our website, published in 2003 in the Journal of the American Podiatric Medical Association. When he examined his specimens, nobody had any inflammation. All 50 of them had dead tissue or degenerated tissue, which was a shock and a surprise to all of us. And we'd sit around the seminars talking about, how can this be dead tissue? Because some of these people are young people. And these people are not folks that have diabetes. They're not smokers. I feel their pulses, their feet are warm, they've got hair. There's nothing wrong with their circulation until they put on the kind of footwear that we talked about at the outset of the show. And this is pivotal for anybody listening today who has heel pain, this kind of heel pain, if it's fasciosis. I'll mention a study done in 2009 in the Journal of Foot and Ankle Research, not on our website, but maybe you could look it up. A group of researchers took people's big toe and purposefully put it in a bunion. And then they took an ultrasound machine and they measured the blood flow coming into the bottom of the foot, right where people get plantar fasciosis. And when the toe was in bunion position, there was a 22.4% reduction in blood flow to the area of the heel where people hurt first thing out of bed in the morning. So it's no longer a mystery why this does not respond when we treat it as if it's an inflammatory entity. It's also no strange mystery when people get their big toe out of bunion position and resolve their plantar fasciosis. And so to your earlier point, Mike, this is an example of where we shouldn't be treating the location of the pain, because in plantar fasciosis, it's not where you hurt under the bottom of the heel. There's a muscle there that tugs on that very location, and not only tugs on the plantar fascia and the heel bone, which makes a spur, which doesn't hurt, by the way, and doesn't need to be removed. But it also, that same muscle strangulates the lateral plantar artery. And that's what that article showed. We also did a similar infrared study, a friend of ours in Spain did, where he took his infrared camera, put correctos on only his right foot, waited a half an hour, didn't put one on his left foot, and captured the heat signal of the blood flow going to the tips of his toes. Tips of his toes were 5 degrees Fahrenheit warmer. So we really do ourselves a terrible disservice to our circulation, believe it or not, with our footwear. And this isn't just stiletto high-heeled shoes. This is our walking, running, hiking shoes. And you can tell if you're doing this to yourself, audience, by pulling the sock liner out, like we mentioned. Superimpose your foot on it. If your big toe is spreading beyond it, you're probably unknowingly creating some circulatory inflow problem. So here's where, again, we try to focus on the big toe as opposed to where the patient hurts. On the other hand, like bunions, once we've outlined the natural educational material, we can treat these people, and I do treat these people. Fasciosis is dead tissue. So in addition to all the education, I will sometimes tape these people. I might do some shockwave on them. And I also inject them. And I inject them with a variety of different things. I inject them with cortisone, believe it or not, which you have to be very careful with cortisone because it can be dangerous if used inappropriately. But I use it for tissue that we don't want to be there. So if somebody comes in with fasciosis, I try to get the body to break it up and clear it out of there. And that's what cortisone does. I will use cortisone for like neuromas, which is abnormal nerve tissue, or ganglion cysts, which is abnormal fluid that we don't want. So we'll also use regenerative injection therapies, which are biological injections designed to, believe it or not, create inflammation on purpose so that the patient can actually heal their own body. And this is prolotherapy, which is sugar solution, platelet-rich plasma, where we take your own blood cells and we put your platelets where you hurt. Your platelets will make new tissue and repair the area. More recently, we're using stem cells, which are immature cells. They don't know what to become. And if you put them in the area of fasciosis, they'll start to remodel that tissue too. Beyond that, we just give it a tincture of time. We generally don't rest these people like I used to. When I thought it was inflammatory, I put them in a boot. I told them don't run. But when I took them out of the boot and I told them to slowly get back into running, their pain came right back, which puzzled me. But it also indicated that stopping activity and curing inflammation or calming inflammation didn't cure their problem. So now I show the patients in the clinic the abductor hallucis muscle strangulating their tibialis posterior artery. They see it with their own eyes. So they're not believing in a theory about this, and it's very straightforward. And that inspires them on their path to fixing their big toe position, which for the most part gets the plantar fasciosis gone. If it doesn't and they come back, then we put our thinking cap on, like I mentioned before, and start asking, is there something else going on? Is this person not well? Or are they on a medication? Do they have another disease? Those people are fairly rare, but if people don't respond, we start testing a little bit more.
So the myth is busted. Dr. McClanahan did a nice job of explaining it. You can have a bone spur, but it is asymptomatic. The pain can be from something else. They've actually done scans where they look at any parts of the body, show a bone spur, and the patient is asymptomatic. In other words, no pain associated with it.
So if you are still having heel pain specifically, we would like to take a look at your footwear because as Ray McClanahan talks about, you want to have a type of shoe with 0 drop and a wide toe box. Brad and I are both wearing those style shoes. We have 3 different brands here. There's many different brands. We don't endorse one specifically, but just find something that's comfortable for you. These are very minimalist. You can see there's not much cushioning. These are still 0 drop because the distance off the floor from your toe to your heel is the exact same. But as you can see, there's much more cushioning. So just try which one works good for you. And they should feel comfortable, but just take your time if you've been wearing normal shoes your entire life, because different muscles and ligaments have to get stronger and stretch out.
But wait, Mike, there's more.
There is.
Yeah, well, we're talking 0 drop, but a very other major component is a wide toe box. You look at these, all have one common denominator. They all have this weird shaped toe. It doesn't have the typical pointed toe, wide toe box, so your forefoot and the bones in your forefoot can relax and not get squished together, creating a lot of problems.
And if you didn't catch it, Dr. Ray was explaining that's how your vascularity gets not pinched off, gets the blood flow to your plantar fascia, which is probably causing your foot pain and not the heel spur.
Right.
Anyway, we have another video if you are having foot pain. Actually, if you just want to watch the whole interview with Dr. Ray McClanahan, because he talks about all foot issues, you can click the video link on the screen and comment if you happen to wear shoes like this.
That's right. It is a really good video. I listened to the podcast, very educational and entertaining.